alphabetically. So we'll first tackle the Pasikidi, Credence, and then Jupiter. So first, let me call on the group of the Pasikidi, our representative who will share your document or answers. Please go ahead and share your screen.
Hey, wait, what?
Okay, you may start. So first, let's hear what is the clinical scenario.
So, good afternoon, everyone. So, for our clinical scenario, we have you are a medical intern currently rotating in the medicine OPD when you heard your consultant nephrologist and resident discuss a case of a 40-year-old male patient who sought follow-up consult. On review of his medical history, he is a patient with type 2 diabetes, currently on metformin with uncontrolled diabetes. He has controlled hypertension with usual BP of 110 over 80 millimeter per mercury and no other comorbidities. During the consultation, the patient asked the resident what are his chances of having to undergo kidney dialysis. He mentioned that he has a neighbor who was also with type 2 diabetes who underwent dialysis but eventually died. He is afraid of the cost of undergoing dialysis and also wants to know his chances of survival. Your residents were discussing with the consultant if it was okay to start a new medication that could benefit him regarding his concern about kidney failure. The resident was suggesting starting a sodium glucose co-transporter 2 inhibitor to reduce chances of death from kidney failure and reduce the worsening of the kidney function. Still unfamiliar with the current evidence on the prevention of mortality due to renal causes and worsening of kidney function with SGLT2 inhibitor among patients with type 2 diabetes, you excuse yourself and search Medline locating and retrieving the following article. The Paliflozin in patient with chronic kidney disease by Crispix et al.
Okay, let's move on. So what are the relevant information you have gathered from this clinical scenario?
So we have here a table. So for the sex, patient was a male. For the comorbidities, um, the patient has controlled hypertension with usual BP of 110 over 80 millimeter per mercury. For the race, the patient is Asian. For the age, patient is 40 years old. Age group is adult. For the pathology, it was not clearly stated in the clinical scenario. However, the patient seems to have renal failure and worsening kidney function and might undergo dialysis. For the socioeconomic status, it was not specified in the clinical scenario, but we assume that the patient belongs to the middle class. For the intervention of interest, we have sodium glucose co-transporter 2 inhibitor, and for the outcome of interest, we have reduction in chances of death from kidney failure and worsening of kidney function.
Hold on, can you go back to your scenario, please? Go up to the scenario. Okay. Um, from students from the other group, they mentioned that pathology was not stated or was not clear. Do you have any or do you have a different opinion regarding the pathology of the patient? Anyone? From the other group? Let's say anyone from the Jupiter group. What is or is there an underlying pathology stated? Basically, what is the main condition of the patient or the main disease? Shaina, what do you think? Givonna said type 2
Doc,
diabetes.
yes po, type 2 diabetes po.
Okay, I agree. So, okay, so Seth, go ahead and scroll down, or Victor, scroll down to your um, characteristics. Okay. Page 2, please, page 2. Scroll up. Page 2, page 2. So, go back to your characteristics. Okay, there. So here, my only comment is that for pathology, it's actually stated. Basically, when we say it's pathology, what is the underlying condition of that patient? So here, you will notice that what surrounds or what is pertinent would be the patient has type 2 diabetes. So that's actually the underlying pathology that that you have or should have extracted from this scenario. But overall, I agree with the characteristics that you have identified. Okay, let's move on. Can you now identify what are the elements of interest from the clinical scenario?
So from the clinical scenario, we have now the ECO. So for the population, we have a 40-year-old male patient with controlled hypertension and uncontrolled type 2 diabetes. For the exposure, we have the SGLT2 inhibitor, and for the comparison, it was not stated in the clinical scenario. Um, for the outcome of interest, we have reducing chances of death from kidney failure and reducing worsening of kidney function. So, following now the recommended syntax in phrasing the clinical question, we have among adult male patients with controlled hypertension and uncontrolled type 2 diabetes, how effective is SGLT2 inhibitor in reducing chances of death from kidney failure and reducing worsening of kidney function.
Okay, agree. What are the elements of interest from the journal article?
So from the journal article, we have a population adults with or without type 2 diabetes who had an estimated glomerular filtration rate of 25 to 75 ml per minute per 1.73 meters per of body surface area and urinary albumin to creatinine ratio of 200 to 5,000. Exposure of interest, that is the pagliflozin 10 milligrams once daily. For the comparison, we have placebo, and for the outcome, we have decline in the estimated GFR of at least 50% end-stage kidney disease or death from renal or cardiovascular causes. So following the recommended syntax, we have the um, research study question among adults with or without type 2 diabetes who had an estimated GFR of 25 to 75 ml per minute per 1.73 meters squared of body surface area and a urinary albumin to creatinine ratio of 200 to 5,000. How effective is dapagliflozin compared to placebo in reducing the decline in estimated GFR of at least 50% and stage kidney disease or death from renal or cardiovascular causes?
Okay, very good to set. Don't forget the qualifier. It's not really reducing the estimated, but reducing the decline in the estimated GFR. Okay, do we have directness? Is the research question elements enough to answer or direct enough to answer the clinical question? Victor Chilon, is it direct enough? Hello? Can you still hear me?
Yes, sorry, Doc.
So is
I
go ahead, Victor. Is it direct?
Stop.
Can you show us the tabulation?
Yeah, this one, the appraising directness.
Second table, the table after that.
Yes, doc.
You kindly discuss this.
Yes, doc. For the population, we have a 40-year-old male with controlled hypertension and uncontrolled diabetes type 2 diabetes. For the exposure, we have SGLT2I inhibitor. For the comparison, it was not stated. And for the outcome, it is reducing the chances of death from kidney failure and reducing the worsening of kidney function. For the research question in populations, adult with or without type 2 diabetes who had estimated GFR of 45 to 75 ml per minute per 1.7 meter of body surface, meter square of body surface area, and the urinary albumin to creatinine ratio of 2000 to 5000, 200 to 5000. For the exposure, we have dapagliflozin, 10 mg once daily. For the comparison, we have placebo, and the outcomes are declining in the estimated GFR of at least 50% end kidney stone diseases or death from the renal or cardiovascular causes. And these are direct enough from
Okay, hold on.
this.
So, a follow-up question. Let's say you have this exposure between or the intervention of interest between the clinical question or scenario and the research article. So, the follow-up question is, when will there be a mismatch in terms of your exposure or intervention? What are the possible scenarios that tell us that it's not direct enough or there's a mismatch? Victor,
Yes, doc.
what what about the intervention will tell us if there's a mismatch? In particular, something to do with the intervention itself.
Doc, there can be diabetes.
No. I'm talking about. So remember we discussed, although it's weeks ago already, but when we compare the different elements of interest, we are looking at the characteristics of the population, what are the intervention, what is compared to, and the outcomes of it was measured, etc. So in terms of exposure or intervention, so what can make the intervention or exposure that is of interest in the scenario be different from the ones in the research journal article or vice versa? So what can change this or what can make it different or have a mismatch with those studied in the article compared to what is being asked in the scenario?
Same drug classification.
So that's one. So classification sometimes they although so what about it? What about the drug class or classification? So how can it be a mismatch or how it can be different?
It can be either same drug or different drug classification, but if there are like use the same category of drug, and for the other we use the different category of drug.
Okay, so that's one. So more specifically, if you remember pharma, so how do we classify? How do we describe drugs in general? Its use, its character, the pharmacodynamics or pharmacokinetics. What about drugs? So one is, for example, same as you mentioned, they belong to the same drug class but are of different molecule. What else? How about Suzette? What else can make uh, what can make uh, and the exposure in the scenario have a mismatch with the exposure or intervention in the journal article? So we have same drug class but different molecules. What else? John Peter, what do you think? what can cause a mismatch in the exposure? Um, something to do with the drug. It's written there. There are clues there.
Ay, yes po, Doc. Siguro po, Doc, yung how is it taken po, Doc?
Specifically what?
Yung dose po, Doc.
Those
Those and what else apart from those? Those. How do we prescribe ba? Do we just tell them the dose?
Frequency rin po, Doc.
Shilon mentioned frequency. So please remember that. So what can cause mismatches in exposure? Although they belong to the same drug class, they may be of different molecules, so that's one. Second, the drug itself. They may be the same drug but given in different doses or given in different frequencies. So we have doses, frequencies. What else is the characteristic that can be different? So how is it taken? So specifically, how do we give these medications? I mean, in general, there are medications given differently. So what are the examples? John Gabby or anyone.
Doc oral po, Doc, can also be IV po, IM.
So what to look out for? Look if in the study whether they are giving it the same way that it is intended in the clinical scenario. So if you're asking for an oral medication, so the study that you should have retrieved in terms of your search, evidence search would be those that use the oral route as well. So there is a mismatch if the study you found actually used IV or IM, for example, if there's a drug that is given in so many routes, whereas you want to actually see oral the drug being given orally. Okay, so let's move on. So can you answer the directness question? Does the study provide a direct enough answer to the PO for the clinical scenario? From the devastating.
Yes po, Doc.
What do we do now?
We validity po, Doc. Tama ba?
We appraise validity. Okay. Let's move on to validity.
So after assessing the directness, we now appraise the validity. So for the first question, were the patient randomly assigned to a treatment group? So for our assessment, we said as a yes. The justification is it is because in the in the clinical
Correct kaya
in
itong
the
not applicable tapos placebo. Direct.
Hello. Someone can mute first when you're
Wala
not
namang binigay eh.
who is speaking.
si Petre po, Doc.
Okay.
Ay,
Okay.
yung sa group po namin. Sorry, Doc.
Okay. Go ahead, Sheila.
So for the first questions, we answered yes, it is valid, and they were randomly assigned because of the research in the journal. We can found it in the abstract method, page 1, the first column of the journal article. It is written there that we randomly assigned for 4,304 participants with an estimated GFR of 25 to 75 ml. So, in conclude that the what they call this, that the sample here were randomly assigned because of the word random.
Okay. So, what keywords do we look for when we answer this validity question? Sheila, what are the keywords that we look for? You mentioned it already. Can you repeat it for the class?
Randomly po, Doc.
Randomly, randomized. etc. So, Chilan, why do we want the study to be randomized? What do what is the aim of randomization?
To avoid bias po.
I agree, but more specifically, what does randomization do? After randomization, what do we have? What is the result of randomization? Let's say you have a population and you will get a sample and then you will randomize treatment group and to control group. So randomization, after randomization, what do you get? The clue is here already. So after randomization, what do you get? For example, you have a treatment and then you have a comparator. You're comparing a treatment to a comparator. Let's say here, we're comparing dapagliflozin with placebo. So what do we aim to do, establish, or achieve in doing the randomization? Would you like to call a friend? Who would you like to, apart from, I mean, not in your group, who would like to call on to help you?
Siya ay man.
Sa Ina, what do we aim to accomplish when we randomize?
Doc, I think po, for the treatment po, for the control group and for the treatment group po, Doc.
Yes, agree, but more, I mean, it has something to do with the treatment group and control group. So what about it?
For each treatment to equally be assigned to the groups po, Doc.
Or you're missing a keyword, but that's correct. So, but the more precise answer is that for each of the participant or patient have equal chances to be assigned to either group. So that's one. And what is the result of having randomization? So you will have two equal groups based on randomization. Is that clear? So it's here in the diagram I drew.
Yes po,
After
Doc. Thank you po.
randomization, you have to. Okay. Thank you, Shaina. Go ahead, Shilon. Move to the next validity question. And I hope it's clear for the others as well. Why we randomize and what's the meaning of randomization. Next. Was allocation concealed?
So for the second question, what was the allocation concealed? So we answered yes. You can refer to the journal again. We we found written on the journal that the investigator used an interactive voice response or web response system to determine trial group segments.
So why do we need to conceal? Or why do we need to assure that allocation was concealed? What does it do? Anyone? What does allocation concealment achieve?
To ensure po that this it is not altered by caregivers who can unknowingly or tend to disturb the sequence po.
Agree. So it aims to preserve the randomization process. Okay, move on.
For the third question, were baseline characteristics similar at the start of the trial? So we answered again yes. We found a table, it's a journal, and the characteristic of our patient in the clinical scenario has the same baseline characteristic with the journal.
Okay. Agree. Next.
So for the Fourth question, were the patient blinded to treatment assignment? So we answered yes. So we found on the journal, it was written that the trial was randomized, double-blind, and placebo-controlled multi-center clinical trial. So the keyword here that is enough or suffice for us to answer yes was the double-blind.
Okay, move on.
For the fifth question, were the caregiver blinded to the treatment assignment? So we answered yes also. So our justification would be what we found in the journal is that the trial was randomized and double-blind and placebo-controlled, and the details regarding the trial design and baseline characteristics of the participant.
What is the harm when caregivers unknowingly or knowingly know which patient receives what kind of intervention?
They will be more biased sa mas may problem.
For example, if the caregivers know that the patient is taking the intervention drug, what do you think will be the behavior of the caregivers towards the patient? Will the caregiver pay more attention or less attention to those receiving the active intervention?
If the siguro, if the patient is not really suffering po from any kind of disease, baka mas less pa yung ibibigay.
No, I mean, if the caregiver or the physician, let's say the caregiver is a physician, knows that the patient is receiving an active drug or an active intervention, when it comes to um, observing the patient, will the physician observe the patient more or observe the patient less?
Yes, the physician would observe the patient more.
So what do we call that bias? Would you know? Starts with letter P. And ends with mans. Per, perfor, performance bias. So when, for example, a physician or caregiver pays more attention to one group over the other, it falls under performance bias. So I agree with your answer. If the caregivers are not blinded, it will lead to bias. Okay, were the outcome assessors blinded?
According to our assessment for doc, they are blinded because there were an independent committee whose members were unaware of the trial assignment.
Agree. So why do we need to blind the outcome assessors? So why do we need to blind the outcome assessors?
For the results doc to be not for the outcome
To be what?
parang overly favor for the overly favor to the intervention drug.
Well, partially correct. But more specifically, of course, the general answer would be is to avoid bias. Let's say the drug is a drug for malignancy, and the outcome assessor, the outcome what we want to find out is if the patient developed cancer, and our outcome assessor is a pathologist. What would happen if you send out a biopsy to that outcome assessor and he or she knows that the patient received the intervention? How will he or she approach assessing the outcome, or for example, looking at the biopsy? What do you think? Again, will he or she pay more attention to the biopsy or give it less attention?
For attention to
And that would lead to what?
performance bias again.
Yes, or yeah, one of the things would be still under performance bias. Okay, next question, please.
So for all the patient analyzed in the group to which they are originally randomized, so our assessment answer would be yes. So the primary efficacy of analysis was based on the intention to treat population, which included in all undergone research.
So what
The keyword
keywords are we looking for here?
the IDD or the intention to treat.
Agree. Move on.
So was the follow-up rate adequate? So we answered yes here. So I wala po ata yung yung justification. But we have here the sensitivity analysis po that can answer if the follow-up rate was adequate. So for our sensitivity analysis, we concluded, so the total population of the journal was 2,152, and under the treatment or the events that happened on the treatment group were 142, and the event that happened or the events that happened under the placebo group were 243 patients. So we under saan po ba yun? Sa appendix po ata to. I found under the appendix that the dropout under the treatment group there were 10, and under the placebo there were 5.
Okay.
So we computed for the step 3 we computed we create a worst case scenario for those group.
So we did the worst case scenario, best case scenario.
For the treatment.
So what were your conclusions?
So the conclusions could there were no significant difference between the treatment and placebo group. So there were enough, right? There were not much dropout.
Okay. Just a few comments. So, move the slide, the page. So here, I agree with your computation. However, they should not be here because the placebo should not, have 0. So technically, we don't count it at all. Or, I mean, tama pala. Dito pala sa interpretation. The interpretation should have been, there were no changes in the proportion from the best case and worst case scenario. Therefore, the follow-up rate is adequate, or there were not too many dropouts. Do you understand that, sila?
Yes,
So specify lang na kasi what we are comparing here is step 3 and 4, such that the proportion or the rate of the event should not change drastically, such that it would point to the opposite direction when you do the best case and worst case scenario. But I agree with the step, and I agree with the conclusion. So how many yeses do you have? Validity?
we have 7 validity questions and all of them were yes.
Actually, you have 8, and one of them are.
8 pala. Sorry po.
It's okay. So what do we do next?
We assess we appraise the results po.
Okay, let's go to the results. So here, my question is, what is your outcome? Is it dichotomous or continuous? Binary or dichotomous is yes, no, presence or absence. Continuous is measured in a scale, so it can be interval or ratio.
We answered
Oh, go ahead.
continuous po. because po, Doc, what the outcome that we are assessing po, Doc, is the yung GFR po, Doc. There
Is it the GFR or the number of patients who had a decline in the GFR?
Yes po, Doc, the number of patients who have declined in GFR.
So if you have number of patients or proportion, what is your outcomes?
Dichotoms po pala dapat.
And then, how did you classify your outcomes? The bad negative outcome or a good positive outcome? Are we preventing a bad negative outcome or are we promoting or inducing a good positive outcome?
We're preventing bad negative outcome.
So here, I think I noticed this as well with the other rules. I think there was some confusion. So we're actually preventing a bad outcome. So look first at the description of the outcome. It's like death, decline in EGFR, onset of end-stage diseases. So they are bad outcome, but we would like to see or prevent these outcomes if we give the intervention of interest. But don't be confused. No? So with the outcome, we are trying to measure how many actually had these bad outcomes. Therefore, we are classifying the outcome as a bad negative outcome that we are trying to prevent with the intervention of interest. Okay, can you show me your computation? So how did you get 142 into 152, 243 into 15? Can you explain briefly?
So for us to get the
What? D1.
get our treatment.
What is RT? Dapat ako nagtatanong yan sa inyo. What is RT?
Nakalimutan ko po.
Is the risk of
Result.
having the event among those given the treatment? How about RC? The risk of having the event given the what?
Given the
Control or comparator. Agree. So how do you get RT and RC?
So for us to get the RT po, we have to divide the total number of events over the total number of population.
Okay. So I agree with your computations. Move on to ARR.
For us to compute the ARR, we just have to divide the RC and
Divide?
RT. So ayun divide minus po pala, subtract po pala to. So we got 4.69. And for our interpretation, since they are more than 0%, that's the treatment is limitation.
Okay, our RRR, relative risk reduction.
And for the RRR, for us to compute this, we have to subtract the RC to RT and divide it with the RC. And
Subtract
what
RT
we got,
from RC over RC. So what did you get?
we got 42%
Interpretation.
Since the RRR is more than the 0%, thus it is beneficial to them.
Okay, relative risk.
For the relative risk for this to be computed, we must divide the RT to the RC. And we got pwedeng pababa. Can you the so we got 0.58 po. So for the interpretation, since it is less than 1, thus the treatment is beneficial.
What is your number dito say? Interpret.
And for us to get the number, the NNT, we must subtract the ARR to 1. So the ARR is 4.69. Since it is greater than 1, so we are going to use the 100 as the numerator. So when we divide this, we got 22. So for interpretation, for every 22 patients treated with dapat so there is one less death from kidney failure or worsening kidney function.
So comment, this is the outcomes will be based on how it was stated in the article. So it's actually one less case of decline in estimated GFR or end-stage kidney disease or death from kidney disease. But you get the idea. So it's Next, how precise was the estimate of the treatment effect? So how do you report this?
So for precise, so in the journal, we have the hazard ratio of 0.56 global.
So what else do you report apart from the point estimate? So we have a hazard ratio of 0.56 and what? What comes after it?
The confidence interval.
Yes. So can you complete your answer?
There's a so we have the hazard ratio of 0 or the point estimate of 0.56 and the confidence interval of 0.45 to 0.68.
Okay, so how precise was the estimate? So interpret.
For the interpretation, since the point estimate did not cross the line of unity or the number one, therefore the
Is it statistically significant or not significant?
therefore yes po. Therefore the study is statistically significant.
Okay, move to the diagram. So here, supposedly, you'll draw a line and then place it like that. But I do get the point. So, just for visualization, again, for future use, so just draw a line and estimate. But I do get your answer. Move on to the next one. After results, what do we do? We assess applicability. So, are there any biologic issues?
No doubt.
For sex, why are there no biologic issues?
From the journal article we got, it's on page number 8. The study include both male and female patients.
What is our patient in the scenario?
Male.
So, there are no differences. Do you agree? Next, comorbids.
No, it does not affect the applicability of the treatment. We got it from the journal, from the page number 9, safety outcomes and the adverse effect.
One comment is that actually what you're looking for is the comorbidities of the patients recruited into the study. You will compare that if those included or studied or participated in the article by her Smith is the same or has the same comorbidities as the patient in the scenario, which I believe they have the same. How about race or ethnicity?
We answered no, it will not affect the applicability of the treatment because we got it from the journal on the page number 8. Shows a breakdown of patients recruited into the study, and they included those with the Asian race.
Agree? How about age?
But will not affect the applicability of the treatment. And we got it from the journal article on the page number 5, table number 1, which is the mean age of the patient is 62.8 plus minus 12.1 for the DAPA, DAPA 14, and 61.92 plus minus 12.1 for the placebo, which is adult range.
Same age as the patient in the scenario.
Patient.
I mean, is it does the age of the patient more or less belong to the adult range?
Yes, no. It's
Okay. How
adult
about
range.
pathology?
Dog class. Yes, for pathology we mark it does not affect the applicability of the treatment. After searching the paper, there is no published study I could find stating the difference between the pathological pathology of the type 2 diabetes versus the diabetes.
Okay. How about socioeconomic issues?
It may not affect because the rate of disease is 46 bhp, which will be given 7 days 52 weeks, which will be 16,744 bhp. Occupation or socio-economic status of the patient in the clinical scenario was not stated, so assuming that the patient belonged to middle class, then he can afford the cost of the treatment.
let's move on. Individualizing results.
So now let's proceed to the individualizing results. So there are several steps in estimating the individualized effects of treatment. For the first step, we estimate the baseline risk or the patient risk for an event without treatment, which is designated as the RC. So for our study or for our case, the baseline risk is as shown 15% or 0.15. And then next, we estimate the relative risk with treatment using the study result. And to do this, we should first report the outcome of interest. So for the PASIKD, the outcome of interest is to reduce chances of death from kidney failure and reduce the worsening of kidney function. So upon looking into the journal, we have a hazard ratio of 0.56 or 56%. Then for the third step, we estimate the post-treatment risk or estimate the individual patient's risk for an event with treatment, which is designated as the RT. So we have a formula for this, which is RT is equal to RC times RR. So RC is 0.15 and then RR or HR is 0.56 and we just multiply them and then we have an RT of 0.084 or 8.4%. And then next is to estimate the individualized absolute risk reduction or the ARR. So formula for this is RC minus RT. So RC is 0.15 minus the RT, which is 0.084 and it would be equal to 0.066 or 6.6%. And then for the fifth step, we estimate the NNT or
Can
the
you
number
scroll down?
NNT or the number needed to treat using the formula NNT is equal to 1 over ARR. So ARR is 0.066, so it would be 1 over 0.066. And then NNT is equal to 15.15 round up and it would be 60. So now to interpret the NNT, for every 16 patients treated with sodium glucose cotransporter 2 inhibitor or the BAP closely, there is one less death from kidney failure or worsening of kidney function among patients with that should be type 2 diabetes.
To set what is the ideal NNT? To set. Follow-up question, what is the ideal NNT for any given intervention? Anyone remember that? What is the ideal NNT?
Doc, 5 and below.
Your, generally yes, but hypothetically speaking and logically speaking, what is the most ideal NNT? Give me one number. Remember NNT? What's the interpretation for every NNT number of patients treated? You get one less case of death. So given that, what is the ideal NNT?
Doc, 1 po. 1 po, Doc.
Yes, it's 1 actually. So as much as possible, we want to find a drug that if we give it, we immediately see 1 reduction in case. So if you see the comparison of NNTs and eventually cost, if your drug and if your intervention's NNT is as close as to 1, you would say that it is most likely to be more cost effective and most likely to have an impact in terms of reducing the burden of the disease. What's the next part to this?
Computing the cost.
So what's the final cost?
The final cost would be 267,904 pesos.
Interpret.
For the interpretation, we need to spend 267,904 pesos by giving out SGLT2 inhibitor risk, benefits, and cost of the treatment.
Okay, noted. So remember our discussion previously, even if the drug or the intervention is costly or there's minimal improvement, but there's improvement, we still need to discuss that option to the patient and allow him or her to arrive at a decision after we give them the information they need in order to arrive at an informed decision regarding their treatment. Okay, thank you, Victor, Suzette, and Chilon. Next group, please. Credence.
Good evening, Huda. So, for our credence, can you hear me?
Yes, go ahead.
So, for our credence, we have a clinical scenario of you are a medical intern currently rotating in the medicine OPD when you heard your consultant nephrologist and resident discuss a case of a 55-year-old female patient who sought follow-up consult. On review of her medical history, she is a patient with type 2 diabetes, currently in metformin with uncontrolled diabetes. He has controlled hypertension with usual BP of 110 by 80 mmHg and no other comorbidities. During the consultation, the patient asked the resident what are her chances of having to undergo kidney dialysis. She mentioned that he has a neighbor who was also type 2 diabetes who underwent dialysis but eventually died. She is afraid of the cost of undergoing dialysis and also wants to know his chances of survival. Your residents were discussing with the consultant if it was okay to start a new medication that could benefit her regarding her concern about kidney failure. The resident was suggesting starting a sodium glucose cotransporter inhibitor to reduce chances of death from kidney failure and reduce the worsening of kidney function. He mentioned that there are new found evidence on renal protective effects and potential benefits as presented in lecture from a recent clinical conference. Still unfamiliar with the current evidence on the prevention of mortality due to renal causes and worsening of kidney function with SGLT2I among patients with type 2 diabetes, you excused yourself and searched Medline locating and retrieving the following article.
What are the relevant characteristics of the patient in the scenario?
So the characteristics are sex, she is a female. The comorbidities are controlled hypertension. The race is not mentioned. Age is 55 years old and pathology will be type 2 diabetes. Socioeconomic, not specified, but she is afraid of the cost of the treatment, which suggests that she is not that economically strong. Intervention of interest is sodium glucose cotransporter 2 inhibitor, and outcome of interest is prevention of mortality due to renal causes and worsening of kidney function.
Okay, Salma. Move on to the elements of interest.
So for the elements of interest, uh, uh, we have population from clinical scenario 55 years old female with type 2 diabetes, and exposure or intervention is SGLT2I. Comparison is not specified, and outcome will be prevention of death due to renal causes and worsening of kidney functions. So phrasing the clinical question will be among 55 years old female patients with type 2 diabetes, how effective is SGLT2 inhibitor in preventing death due to renal causes and worsening of kidney functions?
Okay, one comment. Sorry, Salma. So one comment with your physical question. So you can either keep it as specific as 55-year-old female patients or just place adult female patients. That will also be acceptable. Go ahead, Salma. How about the elements of interest in the research journal article?
The element of interest from the clinical scenario is population is patients at least 30 years old with type 2 diabetes. The exposure is canagliflozin and comparison is placebo, and outcome will be the primary outcome was a composite of end-stage kidney disease, dialysis for at least 30 days, kidney transplantation or end,
Scroll down.
or an estimated GFR of more than 15 ml of per minute per 1.73 m square, sustained for at least 30 days according to central laboratory assessment, and doubling of the serum creatinine level from baseline. Average of randomization and pre-randomization value, sustained for at least 30 days according to central laboratory assessment, or death from renal or cardiovascular disease. So for this, the phrasing research question will be, among patients at least 30 years old with type 2 diabetes, how effective is canagliflozin, um, SGLT2I or sodium glucose cotransport inhibitor compared to placebo in preventing composite of end-stage kidney disease, doubling of the serum creatinine level from baseline, sustained for at least 30 days according to central laboratory assessment, or death from renal or cardiovascular disease.
Okay.
Next one is appraising directedness. As mentioned in the clinical question, the population of interest mentioned in the clinical question is like 55-year-old female with type 2 diabetes, whereas in research question, it is the patients at least 30 years old with type 2 diabetes. Whereas exposure or intervention in the clinical question includes SGLT2I, which is sodium glucose cotransporter 2 inhibitors, whereas in research question it is canagliflozin, as well as SGLT2I is also mentioned. Whereas in comparison of interest, in the clinical question is not mentioned, whereas in research question it is placebo, and the outcomes mentioned in the clinical question includes prevention of death due to renal causes and worsening of kidney functions, whereas in research question it is the primary outcome was the composite of end stage kidney disease, that is dialysis for at least 30 days, kidney transplantation, or an estimated GFR of less than 15 ml per minute per 1.73 meter square sustained for at least 30 days according to the central laboratory assessment. Doubling of serum creatinine level from the baseline, that is average of randomization and pre-randomization values, sustained for at least 30 days according to the central laboratory assessment, or death from the renal or cardiovascular disease.
So are they direct enough?
Yes, for doc. When compared to population of interest, in both clinical question and research question are direct product, because irrespective of the age and gender, the main problem is type 2 diabetes. Whereas in exposure or intervention, it is similar because both of them includes SGLT2I. And when compared to comparison, which is not mentioned in clinical scenario and research question, it is placebo. So it can be direct product, because in clinical question the comparator is not mentioned, whereas outcomes are also direct product, because both of them deals with the death caused due to renal causes and worsening of kidney functions.
Okay, agree. Just to clarify, when your clinical question does not have a comparison, so you don't need to assess directness. So just also put here not applicable, since one of the columns are not stated or not specified. But the rest I agree. Just a minor clarification. Go ahead. Next, please. Validity. Is it direct enough? Yes. Then go to validity. Kindly discuss your answers.
So first, were the patients randomly assigned to treatment groups? For the assessment, we said yes. We can refer to the page 2297, first column, second paragraph, under the prior procedure section. The patients were randomly assigned in a double-blind fashion, 1:1, to receive either canagliflozin, 100 milligrams orally once daily, or matching placebo with the use of randomly permuted blocks. So next is, was allocation concealed? We also we said yes. We can refer to page 57 under the double blind treatment phase, that which they said there that they will be randomly allocated to treatment with canagliflozin 100 milligrams or matching placebo in a 1:1 ratio. Next question is, were baseline characteristics similar at the start of the trial? We also said yes. We can refer to page 2298, first column under the results section. Uh, it stated there that the baseline characteristics of the patients were similar in the two groups.
Peter,
Sorry. Yes,
Peter,
po, Doc. Yes.
how do you know that randomization was successful?
Randomization success.
You mentioned that when we randomize, you arrive at two similar groups. So how do you check if we have achieved a successful randomization such that the two groups are similar? What do you check? What do you check?
Doc, yung baseline characteristics po.
So what about the baseline characteristics? So what does it mean? What should it reflect?
Um, that there were similar po, Doc, in the two groups.
Okay. So we can check if randomization is successful by looking at the baseline characteristics and seeing if indeed across the different prognostic uh, factors or the baseline characteristics, if they are similar between the two. Okay, move to blinding.
For the next question, were patients blinded to treatment assignment? We said yes. We can refer to page 2295, second paragraph under methods. In this double-blind randomized trial, we assigned patients with type 2 diabetes and albuminuric chronic kidney disease to receive canagliflozin, which is an oral SGL2I, at a dose of 100 milligrams daily or placebo. Next is, where caregivers blinded to treatment assignment. We said yes. We can refer to page 2295, second paragraph. Under methods, uh, same statement. In this double-blind randomized trial, we assigned patients with type 2 diabetes and albuminuric CKD to receive canagliflozin, which is an oral SGL2I, at a dose of 100 milligrams daily or placebo. Next is, were outcome assessors blinded to treatment assignment? We also said yes. Same justification with the caregivers blinded to treatment assignment. We can refer to page 2295, second paragraph under the methods.
Hold on. So you mentioned outcome assessors were blinded based on this. Is that correct?
Yes, po, Doc.
Okay. So actually, as mentioned previously in our discussion, when you mean by double blind, by convention, it's the patient and the caregiver. So when you're looking for whether outcome assessment assessors were blinded, you will look for keywords such as an independent data monitoring committee, adjudication committee, and the keyword would be they are independent. So here I saw under in the same patient the methodology under safety evaluation. So they mentioned that all renal and cardiovascular outcomes that were part of the primary and secondary outcomes were adjudicated by independent adjudication committees whose members are unaware of trial group assignment. So that's what you will be looking for when you look at the outcome assessments. But the rest I agree. Okay, go to the next validity question. Were all patients analyzed in the same paper?
Yes po, Doc. Because we can refer to page 2297, second paragraph. Right column under statistical analysis. In the intention to treat population, we use a stratified Cox proportional hazards model to analyze the primary and secondary outcomes according to the category of estimated GFR at screening.
Okay, was the follow-up rate adequate?
Yes po, Doc. We can refer to page 2301, first paragraph, right column under effect of intermediate outcomes. On average, levels were lower in canagliflozin group for systolic blood pressure by 3.30 millimeter mercury and 95% confidence interval to 2.73 to 3.87, a diastolic blood pressure by 0.95 millimeter mercury, and a body weight of 0.80 kilograms. And the geometric mean of the urinary albumin to creatinine ratio was lower by 31% on average during follow-up in the canagliflozin group.
So for this, my comment is I agree with the justification, with the answer, but not with the justification. Did you do the sensitivity analysis?
Yes po, Doc.
Sure it will.
So for the sensitivity analysis, um, for the total number in the treatment group is 2,202 and in the control group is 2,199. So we got the 2,193 by uh, subtracting the dropout in the treatment group, which is 9. So we can divide 168 divided by 2,193. And in the control group, same 202 divided by 2,186. So for the worst scenario for the treatment group, by assuming all dropouts in this group had the bad outcome, and the dropouts in the control group had a good outcome. So 168 plus 9 divided by 2,193 plus 9 is equal to 177 over 2,202, and then which is equal to 0.080. Now for the control group, 201 plus 0 divided by 2,186 plus 13. So we got 0.091. For step 4, create a best scenario for the treatment group by assuming the opposite. Um, 168 plus 0 over 2,193 plus 9 is equal to 0.076. For the control group, 201 plus 13 over 2,186 plus 13 is equal to 0.097. So, for the conclusions,
Hold on, Peter.
yes po,
So
Doc.
step number 3, between treatment and control group, which group had more events, which had more death from any cause? Treatment group or the control group?
From,
Because this outcome is death from any cause. Anyway,
yes po, Doc.
so which of the two groups had more death from any cause?
Doc, yung control po.
Okay, agree. So that's why the sign is like this. Step 4, which of the two groups had more events? Treatment group or control group?
Yung control group din po, Doc.
So can you interpret?
So, uh, so
Were
we're
there
the
too many dropouts? Is there a sudden shift or change in the estimates when you did the worst case and best case scenario, or did they remain the same?
um, parang remain the same po, Doc.
Hindi parang, it remain the same talaga.
Remain the same.
So, what will be your conclusion now?
Doc, for the conclusion, so that
So
where the
just answer the
conclusions of
question, were there too many dropouts?
no po, Doc, because the treatment group had fewer bad events on the best case scenario compared to the control group. And on the other hand po, Doc, the control group had more bad events on the worst case scenario po, Doc.
Actually, no. You actually already answered that you answered or you agree that we don't have too much dropouts. Why? Because the events actually stayed the same. There are more deaths from any cause in the control group, be it in the worst case scenario or in the best case scenario. Do you agree?
Um, yes
Diba?
po.
The statement kasi said there were fewer or um, yung opposing or changing more. So actually there are not too many dropouts. Tama ba? or did I confuse you? Anyway, um, it remains the same, and therefore we are confident that the dropouts did not alter or deviate our estimates in the results, and therefore I agree with your answer in the upper portion that follow-up rate was adequate. Okay, let's move on.
Next, doc, is the appraising results. So for the what the outcome interest, the prevention of death due to renal causes and worsening of kidney functions. So the outcome is a good positive outcome po, doc, and it is a dichotomous variable po, doc.
Hold on. So for this again, so use the outcome that is or how it is stated in the journal article. So for this is actually I think the outcome in the clinical scenario. So you need to find something that is similar that is reported in the journal article. So that's for a secondary outcome, specifically the end stage kidney disease, doubling of serum creatinine level for renal death. So that's one, but more or less you get the idea. For is it a good or positive outcome or a bad negative outcome? Are we remember if it's a bad outcome, we are preventing it. If it's a good outcome, we want to induce it.
Ay, bad negative po, doc.
Okay, and then I agree with the dichotomous outcome. Go ahead. Can you discuss the results or how you computed for the treatment effects?
Doc, for the RT po, it is given po, so no effect. For the solution po, 153 over 2,202, which is equal to 0.6. Same goes with RC, doc. It is also given. So, 224 over 2,199 is equal to 0.10. And we interpreted this po, doc, as no effect since
Okay.
given.
So I agree. It should not be interpreted actually. So it's a given. So technically, you don't interpret this because this is the component of the different estimate of effects, the ARR, relative risk reduction, and RR. So let's proceed with the computation. So how did you compute for the absolute risk reduction?
For the absolute risk reduction po, doc, RC minus RT. So 0.10 minus 0.06 is equal to 0.04. So we interpreted this as beneficial because 0.04 is greater than 0 po. Then for the RRR or relative risk reduction for the solution, RC minus RT over RC, which is 0.04 over 0.10, yeah, and it is equal to 0.4. So it is also beneficial because 0.4 is greater than 0. For the relative risk, RT over RC, so 0.06 over 0.10 is equal to 0.6. We interpreted this po as beneficial as well because it is greater than 0.
Okay,
Then,
just a comment. So here, this should have been expressed in percent, so not in percent. And then here, I agree with decimal. But however, are we looking at it if it's greater than 0? So this is a ratio. So if you remember the interpretation, we are actually looking if it's greater than or less than or equal to 1. So for ARR and relative risk reduction, we use 0. But for the relative risk, we use 1. Okay, so other than that, I agree with answers. Number 93.
doc, for the NNT, um, uh, it is 1 over 0.04 po, doc, which is 25. So for every 25 patients treated with canagliflozin, there would be one less death due to renal causes and worsening of kidney functions among type 2 diabetes patients.
For every 25 patients. Okay, let's move on.
Next is how precise was the estimate of the treatment effect for the outcome interest. The primary outcome was a composite of end-stage kidney disease, dialysis transplantation, or a sustained estimated GFR of less than 15 milliliters per minute per 1.73 meters squared. A doubling of the serum creatine level or that from renal or cardiovascular causes. So for the measure of effect and 95% confidence interval, so 0.70 with a confidence interval of 0.59 to 0.82. So the study outcome did not cross the line po, doc. So meaning it is beneficial and both the upper and lower limit are less than 1 po.
Okay, move on.
So for the figure,
Okay, I agree. So next, applicability. Are there any issues on applicability?
Doc, for assessing applicability, biological issues which include is it does not affect the applicability of the treatment because the study includes both male and female patients, whereas in comorbidities also it does not affect the applicability of the treatment because hypertension is not a contraindication in taking the canagliflozin, whereas when coming to race, it does not affect for dog because the study includes Asian ethnicity, whereas in age also doesn't play an does not affect the applicability of the treatment because the mean age of patients is between 53.7 to 72.1 for the canagliflozin and 54 to 72.4 for the placebo. Whereas for the pathology, it does not affect the applicability of the treatment because there is no significant difference between the pathophysiology of heart failure from different ethnicities. Whereas when compared to the socioeconomic issues, for economic issues, it may affect the applicability of the treatment code because due to the cost and length of the treatment and access to healthcare, this will affect the applicability of the treatment.
Okay, some comments. So always compare your don't move the page. Always compare your issues from the research article to the scenario. So let's say the study included both male and female patients, while the study included a female patient. Therefore, there's no applicability issue in terms of sex and so on. And also here, so I think this is from another appraisal because we're not talking about heart failure. So it's actually type 2 diabetes and CKD. And economic issues I agree as well. So there may be some applicability issues based on your justification. Let's go to the individualization. So can you just tell me what is your NNP?
Doc, for the NNT, in every 15 patients, we get one positive outcome in preventing type 2 diabetes.
So here, my comment would be it's not really preventing type 2 diabetes, but preventing decline in EGFR by 50% and stage renal disease or death from renal and cardiovascular causes. Remember, this is the pathology, but we're trying to prevent what is the outcome reported, which is actually the complications. So that's my specific comment about that. Let's move on to the next part. Cost.
So for cost is for the 18,200 peso, which I think I will offer the treatment to my patient because it depends means I will offer the treatment because it is affordable and it is depends on the patient's economic status on that particular moment if he is able to afford.
Okay. Just a comment on your cost. Remember, you. So what's missing in this calculation, Sally? Before I see the answer, what's missing in this calculation? You forgot to actually multiply it with the NNP. That's why this is particularly low figure. So remember, uh, the formula should be NNE times the frequency of the medication times how many days you are going to take it. So
Yeah, 364 days.
yes, so you forgot to multiply it with the NN. For the interpretation again, it's not preventing diabetes but preventing the outcome reported discuss with. And then would you offer this and give your take? Okay, thank you. Let's move on to the next group, please.
Dok,
Yes, Peter.
parang meron po kasi akong nakita na na heart failure po dun sa journal.
Yeah, but the main pathology is not it's not heart failure. It's um, Credence is a study focusing on the renal outcomes. It's a renal outcomes trial actually.
Okay, noted po.
The heart failure is a secondary exploratory outcome, but not the main endpoint. But it's still related. Just have to redirect it to the main outcomes.
Noted po. Thank you po, Doc.
Okay, next group please.
Good evening po. So for our group, the assigned topic is the Jupiter, and our clinical scenario is for the statins. So the case is you're a medical intern currently rotating in the medicine OPD with your cardiology consultant and resident when a 50-year-old male bank manager sought medical consult due to a slightly elevated LDL cholesterol levels discovered on annual periodic examination. On review of his medical history, he is an apparently healthy patient with no known comorbidities, non-smoker, and non-alcoholic drinker. While they were discussing, the cardiology consultant asked the resident a clinical question: if the patient needs statins aside from the lifestyle modifications to prevent major cardiovascular events such as myocardial infarction, stroke, hospitalization for unstable angina, or death from cardiovascular causes, and increase his chances survival in the long term, considering he does not have any other comorbidities and still economically productive. Still unfamiliar with the current evidence on the effect of statins on major cardiovascular events among apparently healthy patients, you excused yourself and searched Medline, locating and retrieving the following article. So, uh, the relevant patient information we have identified from the clinical scenario. The patient is a male. The comorbidity stated are none. The race is not stated, however, we presume that this is an Asian descent. Age of the patient is 50 years old, and the pathology slightly elevated LDL cholesterol levels. With the socioeconomic factor, the patient is a bank manager, and the intervention of interest is the statins, and the outcome of interest would be to prevent major cardiovascular events such as myocardial infarction, stroke, hospitalization for unstable angina, or death from cardiovascular causes, and increases chances of survival in the long term. So for the elements of interest in the clinical scenario, the population, 50-year-old male with slightly elevated LDL cholesterol levels. For the exposure or intervention, statins, the comparison or control, um, not applicable. And for the outcome, to prevent major cardiovascular events such as myocardial infarction, stroke, hospitalization for unstable angina, or death from cardiovascular causes, and increases chances of survival in the long term. So, phrasing the clinical question, among 50-year-old male patients with slightly elevated LDL cholesterol levels, how effective is statins in preventing major cardiovascular events such as myocardial infarction, stroke, hospitalization for unstable angina, or death from cardiovascular causes, and increasing the chances of survival in the long term? So for the research journal article, the elements, for the population, men 50 years of age or older and women 60 years of age or older with low density lipoprotein cholesterol levels and high sensitivity C-reactive protein levels with the intervention of rosuvastatin 20 milligrams daily, and the comparison would be the placebo. And for the outcome, the primary outcome was the occurrence of a first major cardiovascular event defined as non-fatal myocardial infarction, non-fatal stroke, hospitalization for unstable angina, an arterial revascularization procedure, or confirmed death from cardiovascular causes. And for phrasing the research question, among men 50 years of age or older and women 60 years of age or older with LDL cholesterol levels and high sensitivity C-reactive protein levels, how effective is rosuvastatin 20 milligrams daily compared to placebo in preventing occurrence of a first major cardiovascular event and death from cardiovascular causes?
So is it direct?
Hello po, Doc.
Yes. Go to the next table.
John.
Second table. Number 2. So is it direct enough?
Yes po, Doc. Yes, the study is direct enough to answer the clinical question, and then we can proceed to appraise validity.
Okay, let's go to validity.
For good evening po. For the appraising validity, were the patients randomly uh, assigned to treatment group? Yes. Uh, you can refer to page 2195 abstract methods. It was stated there that it was randomly assigned 17,100 to apparently healthy men and women. And for the allocation concealed, yes, you can refer to page 2197 methods under trial protocol, first paragraph. It was mentioned that randomization was performed and used as an interactive voice response system and was stratified according to the center. For the baseline characteristics, yes, you can refer on page 2198 under table 1. Uh, it it was always stated there the baseline characteristics of the article, and the next one is where the patients blinded to treatment assignment. Yes, you can refer on page 2196 under methods and trial design. It was stated that it was randomized, double-blind, placebo-controlled, multi-center trial conducted. For the were caregivers blinded to the treatment? Yes. It was also stated as well that uh, I wait. Yeah. It was also stated that the article used a randomized double-blind placebo-controlled multi-center trial where outcome assessors blinded the treatment. Yes, you can refer in page 2197 under methods endpoints, second paragraph. It was stated that it was all reported the primary endpoints that occurred through March 30, 2008 were adjudicated on the basis of standardized criteria by an independent endpoint committee unaware of the randomized treatment assignments, and were all patients analyzed in the groups to which they were originally randomized. Yes, you can refer on page 2197 under methods statistical analysis. It was stated that all primary analysis were performed on an intention to treat or ITT basis, and for the follow-up rate adequate, yes, you can refer on page 2199 under results endpoints. The first paragraph that it is stated there that in the test for interaction between the study group assignment and follow-up time, there was no significant violation of the proportional hazards assumption. Oh, so,
Hold on. So for the sensitivity analysis, so actually the proportional hazard assumption is not uh, the direct answer to your remarks. However, I agree that the follow-up rate is adequate. Can you move to your computation? So let me know what is your interpretation and what's the basis. Step 5, basically. How did you conclude what you concluded here?
We found out that the worst case scenario showed fewer bad events for the treatment, while the best case scenario also showed fewer fewer bad events for treatment. Therefore, the dropout rate for this one is acceptable for this study.
Okay, agree. Move on.
Uh,
So here, in interest of time, is it a bad outcome or a good outcome?
Doc, we concluded that it was a good positive outcome, but
What's the correct answer?
I think it's bad po.
And is your outcome dichotomous or a binary outcome?
Sorry po, Doc, di ko po narinig. Sorry po.
Is your outcome of interest dichotomous or a continuous variable? So here it says to prevent this and increase the chance of survival. So how did they report it? Did they count who had the events and who did not, or did they measure a continuous variable?
Continuous po, Doc.
Are you sure?
Wait lang, titignan ko yung chart.
So if you look at the
Chart.
table, what do you see?
Ay, oo
You
nga,
see
ay, dichotomous pala.
n over n or mean plus standard deviation. How was the events reported? Is it n over n, or did you see mean plus minus standard deviation? So this one is binary or dichotomous. This one will be for continuous outcomes. So Giovanna is mentioning that it is a binary outcome or a dichotomous outcome. So let's move on. Again, for the interest of time, can you interpret your absolute risk reduction, relative risk reduction, and your relative risk?
For our absolute risk reduction po, since we interpret and we got 0.83%, we assume that since it is greater than 0%, the treatment is beneficial po.
Okay, relative risk reduction, interpret.
And for the relative risk reduction po, we pointed out 0.4716 or 2.47.16%. Since it was greater than 0% as well, the treatment is beneficial po. And
And the relative risk.
And for the relative risk po, we got 0.5284 or 0.53. And since it is lesser than 0, the treatment is what the heck?
Lesser than 0.
Greater than 0 po, so the treatment is beneficial. Ano nga dito?
Are you sure? These two are actually conflicting.
Nagiting sagot.
Greater than, less than 1. So what's the answer? You still remember our discussion regarding RR? So remember, we have a numerator and denominator. And if our outcome is a bad outcome, something we want to prevent, John Gabby, which side do we want to have more events? The numerator representing the treatment or the denominator representing the control?
Wait.
Yvonne or Shaina, which one of the numerator denominator would you want to have more events to show that treatment is beneficial? Let's say it's a bad outcome, like what we have here, death, Jupiter, so death or cardiovascular events. So which one of this side would we want to have more events? The numerator representing treatment or denominator representing your control? What what will
Is
happen
it
if...
the
Yeah, go ahead.
No,
Go ahead.
is it the numerator beta?
So let's say if you have more deaths in the numerator, what will happen to your ratio? Will it be more than 1 or less than 1?
More than one po.
So if it's more than 1, there are more deaths in the treatment group compared to the control group. Is it beneficial?
Not beneficial.
So but here you got something that is less than 1 and you say it's beneficial. So what should be the proportion of cases or events? Should there be more cases in the denominator than the numerator to have an answer that is less than 1?
In the denominator beta.
Denominator. Do you get it? So we want more events to prove that the treatment is beneficial in the denominator, which represents your control. If you have more events in the treatment arm, it will reflect in the numerator, and therefore your RR would be greater than 1, and it will be deemed harmful. So I hope that you got that logic on how to approach RR. So what's your NNP?
one, one, 121 po. In our interpretation is, sa clinician, we have to treat 121 patients to prevent one additional bad outcome po.
Okay, move on to the estimate effect. So interpret this. Is it significant?
Yes po. Based on the 95% confidence interval, p-value is statistically significant since the interval estimate did not include the null value involved.
Okay,
So,
move on. It's okay, thank you. Move on. We agree with the diagram. Next. Applicability, do we have any issues?
no po. Shall I read
Yes.
the
You can explain why you mentioned yes.
So for the first biologic issue, sex, no, it does not affect the applicability of treatment because the journal included both male and female, and our patient was male. And then for comorbidities, no, it does not affect the applicability of treatment. For our patient, he had no comorbidities, but they in this article they still included patients with some comorbidities, but it wouldn't affect our patient. For our race, it does not affect applicability of the treatment because there were patients who were white, black, Hispanic, and then they also included other or unknown. If you see table 1 in the article, so we can assume that our patient is Asian, so we can fall under the category of other or unknown. And then for age, no, it does not affect applicability of treatment because the study included men 50 years of age or older, and that goes well with our patient because he is 50 years. And then for pathology, it does not affect any applicability of treatment, but there are no supporting statements in the clinical scenario.
Any socioeconomic issues?
For the yes, for the so it does not affect applicability of treatment. And our justification for this was this equation. So assuming that the patient is from the middle class, the patient can afford the total cost of treatment. And then for other issues, we included this question that was in the Google form. Are there cultural issues that may affect applicability of treatment to our patients? And we said no.
Okay, how about individualizing the results? Can you tell me the NNT?
NNT cutoff is 9. So the interpretation of this is that we have to treat 9 people who suvastatin to prevent one additional bad outcome.
Okay, and then for the interpretation of the cost to prevent one out.
So for the
So the interpretation of that would be 294,840 KHP must be spent in order to prevent one additional bladder block.
And you give this to your patient?
Yes, we offering to our patients. We're not really sure about this, Doc, but we just said yes, since it is cost effective and would be beneficial for the population of interest. And also, as a recommendation, you should offer any plans regardless of the cost to your patient, just for their
Okay, I agree. Thank you. So that wraps up our group reports. Are there any questions from any of the groups? Any questions?
None for me po, Doc.
Okay. So we're actually nearing the completion of the course. So for next week, we'll be having sort of an evaluation. Don't worry, it will be an open book, but however, there will be a time limit. So you'll be asked to answer questions regarding or related to the appraisal process. You have heard some of them when I was also questioning you during your reporting. So more or less, it will just revolve around the concepts. But it will revolve around the concepts of how to appraise an article on intervention, systematic review, and diagnostic studies. Our main reference would still be the SGD-EBM book by Dan Sylvester et al. In our past SGDs and discussion that we have for the three modules. So if there are no more questions, I congratulate you. So I'm very satisfied with what we have presented, and I hope you're hearing it with you, especially not just being able to know the terminologies, but really understand in the context of appraising an article on therapy, why do we do the different steps, for example, randomization, allocation, concealment, etc. And especially more than knowing how to conclude, it's really the interpretation and how it will impact your clinical decision making. Okay, so we'll be having the same session on Tuesday, same time slot. We'll be sending the Zoom link again in the Google Classroom. So with that, I conclude our session. So have a great week ahead and see you next week.
Recording stopped.
Thank you po, Doc.
Thank you po, Doc.
Thank you po.
Thank you po, Doc.
Thank you, Doc.